Hello friends, welcome to Creative Medicine. In this lecture, we will learn about. Hello friends, let us now learn some important points about the nipple discharge. Nipple discharge can be of three types. One, it can be either blood-stained discharge, or it can be serous discharge, or it can be black, green, paste-like or grumous discharge. If it is blood-stained discharge can be due to duct papilloma, or it can be due to intraductal carcinoma, or it can be due to duct ectasia. So blood-stained discharge occurs in duct papilloma, intraductal carcinoma and duct ectasia, whereas serous discharge occurs in fibrocystic disease, duct ectasia and also duct carcinoma, whereas black green paste like grumous discharge occurs in duct ectasia. So blood-stained discharge occurs in duct papilloma, intraductal carcinoma and duct ectasia, whereas serous discharge occurs in fibrocystic disease, carcinoma and duct ectasia, whereas blackish and greenish black disease occurs in duct ectasia. If you were asked what is the most common greenish discharge is duct ectasia. If you were asked what is the most common blood-stained discharge is duct papilloma is seen. Then if you see, that is most important. So nipple discharge is of three types. It is blood-stained, serous and blackish and greenish paste is seen. Okay, now if you see the next, it is nipple discharge. So nipple discharge can be either unilateral, serous sanguinous or serous discharge, or even bloody discharge can be there. If it occurs from a single duct, if the discharge is unilateral, young, spontaneous, unilateral, serous discharge is present from a single duct, from one duct, then it is intraductal papilloma. Mostly the cause of the intraductal papilloma is a cause of serous discharge. Then if you were asked what is the mostly the cause of nipple discharge, most commonly it is due to either duct papilloma or it is due to duct ectasia. In this duct papilloma and duct ectasia, nipple discharge is seen. If there is nipple discharge, the chances of malignancy is high, especially if there is bloody discharge which is associated with one duct plus mass, then obviously you should think of malignancy. Okay, so if there is malignancy, then you will see underlying suspicious lesions will be seen. Then cytology will help us to identify the malignant cells. So in this nipple discharge, we do something called as ductography is done. If you do a ductography, what is the primary indication of ductography? Primary indication of ductography is any nipple discharge, especially if the nipple discharge is bled, then you do ductography. Then we have radio opaque. In ductography, how do? You will inject a radio opaque contrast material is injected into one or both the drugs and mammography is performed. After injecting the radio-opaque contrast material, mammography is performed. If there is intraductal filling defects are seen, then it is, if you find that there are intraductal filling defects is seen, then that is ductal papilloma. If you see that there is irregular multiple filling defects are seen like this, if you see multiple filling defects like this, then it is carcinoma. If only one filling defect, then that is papilloma. Multiple filling defects are seen, then that is carcinoma. Then if you see a dilated cystic structure like this in the ductography, then that is dilated cystic structure. Then you can do ultrasonography. If you do ultrasonography, you will see presence of mass or duct ectasia is seen. Then what is the final diagnosis? Final diagnosis is made mainly by the excision of the involved duct. Excision of the involved duct is called as microdocectomy, where you excise the only one single duct which is involved, and even you will have to excise the mass which is present in the breast. Then normally radical duct excision is not done. What is radical duct excision? Radical duct excision is removal of all the ducts. This removal of all the ducts is not done. Okay, next, first important thing here is treatment. In the treatment, how are you going to treat it? Treatment is you should exclude the carcinoma. You should exclude the carcinoma by occult blood test and cytology. And once you are sure that it is a benign lesion, you should have to, simple assurance is important. Assure the patient. If the discharge is proving intolerable, then operate just the remove the affected duct only. That is microdocectomy is done. This is about the nipple discharge. Next we have breast carcinoma. So if you see in the breast carcinoma, this breast carcinoma is most common cancer affecting the woman in the world is breast carcinoma. If you were asked what is the most common cancer affecting the urban woman in India, that is also breast carcinoma. Then most common type of breast carcinoma is adenocarcinoma is most common type of breast carcinoma, and it occurs mainly in the terminal lobular unit. It occurs in terminal lobular unit. Then what is the most common type? Most common type is invasive ductal carcinoma is the most common type. Okay, then what is the most malignant type of breast carcinoma? Most common type is invasive ductal carcinoma is most common type. Most malignant type of breast carcinoma is inflammatory breast cancer. Inflammatory breast cancer is most malignant type of breast carcinoma. Where is it present mostly? Mostly it is present in the upper outer zone. You will see carcinoma is seen mainly in the upper outer zone. And then upper outer quadrant, you see the carcinoma. Then what is the most common site of metastasis? It goes to the bones, and in the bones it produces osteolytic lesions, especially in the lumbar vertebrae. In the femur it will produce the osteolytic lesions, and thoracic vertebrae followed by rib and skull. Okay, what is the most common cause of death? Most common cause of death is metastatic disease is the most common cause of death. This is the second most common cancer related death in women. Most common cancer related death in women and lungs is carcinoma. Lung is the most common cancer related death. Breast carcinoma is the second most common cancer related death. So what are the most common things in breast carcinoma? Breast carcinoma is most common cancer affecting the women in the world and most common cancer affecting the urban women in India. It is most common type of breast carcinoma is adenocarcinoma, and most carcinoma arises mainly in the terminal duct lobular unit. Most common type is invasive ductal carcinoma. Most common malignant type of cancer carcinoma breast is inflammatory breast carcinoma. Most common site is upper outer quadrant. Most common metastasis is in the bone. Osteolytic deposits are seen in the lumbar vertebrae, followed by femur, then thoracic vertebrae, then ribs and skull. Metastatic disease, that is malignant pleural effusion, is the most common cause of the death. So this is the second most common cancer related death in women. If you were asked what is the first most common cancer related death, that is carcinoma lung is the first most common cancer related death in both men, male and females. Okay, next if you see the clinical features, in the clinical features it is early breast carcinoma. If it is early breast carcinoma is actually asymptomatic, then slowly symptoms start developing, like there will be change in the size and shape of the breast. You will see skin dimpling will be seen, nipple retraction, and also single duct discharge will be seen, and also there will be axillary node enlargement will be seen. So if you see the symptoms, all these symptoms are seen, then what about the metastatic symptoms? If the cancer goes to the lungs, it causes breathing difficulty, it causes bone pain, and also symptoms of hypercalcemia are also seen. And also if it goes to the abdomen, there can be abdominal distension will be there, with jaundice will be there. So these are the main clinical features. Then how will you evaluate the patient? Evaluation is mainly, first and foremost, it is done by evaluation is done by triple assessment. In triple assessment you will do clinical examination, and then you will do imaging where you do USG or mammography is done, followed by tissue sampling, which is FNAC or true cut biopsy is done. So you do clinical examination, USG, and that is imaging with USG and mammography, or you do tissue sampling with FNAC or true cut biopsy is done. Now this triple assessment sensitivity is 99.9%. Among all these, if you were asked what is the first investigation is FNAC is the first investigation which is done. Then if you were asked what is the best investigation, the best investigation is actually biopsy is the best investigation. Okay, so this is about the diagnosis and investigation. Now if you see some one-liners, what is the most common cancer in women in India? Most common cancer in women in India is carcinoma cervix. What is the most common cancer of women in the world? It is carcinoma breast is the most common cancer in the women in the world. Most common cancer of urban women in India is carcinoma breast. Now, most common cancer related death in both women and men is lung cancer. If you were asked what is the cancer related death in women, that is second most common cancer related death in women is breast carcinoma. So revise again. Most common cancer in women in India is carcinoma cervix. Most common cancer in urban women in India is carcinoma breast. Most common cancer in women in the world is carcinoma breast. Most common cancer of cause of cancer related death is carcinoma lungs in both men and women. Second most common cancer related death in women is carcinoma breast. So we said the first investigation which is done is FNAC, and the gold standard or diagnosis or investigation of choice is actually biopsy, which is diagnostic is biopsy. So in this case we will see some differences. FNAC is easy to perform and it requires a trained pathologist. Cytopathologist should be necessary. In true cut biopsy, histological specimen is suitable for interpretation of any pathologist. It provides the histological specimen is for interpretation of any pathologist can interpret the biopsy results. Whereas FNAC, for this we need a trained cytopathologist, and FNAC will result in false negative results are more common in fibrotic and well-defined tumors. False negative results are more common. Whereas in true cut biopsy, ER/PR status along with HER2/neu status can be determined in true cut biopsy. These ER/PR status cannot be determined in FNAC. FNAC cannot distinguish between ductal carcinoma in situ and invasive cancer, whereas biopsy can differentiate between ductal carcinoma in situ and invasive cancer. So two important things is FNAC is easy to perform and requires trained cytopathologist, whereas true cut biopsy does not require a trained cytopathologist. Anyone can interpret, any pathologist can interpret a true cut biopsy result. FNAC false negative results are more common in fibrotic and well differentiated tumors, whereas true cut biopsy is mostly diagnostic. False negative results are less. FNAC you cannot use ER/PR status determination cannot be done, whereas in biopsy you can determine ER/PR and HER2/neu status. Here biopsy is actually diagnostic. Biopsy is actually diagnostic choice for preoperative systemic therapy, whereas FNAC is not. FNAC cannot distinguish between the DCIS and invasive cancer. Now, if you see the advantages of FNAC, main advantages are it is painless and no incision is prior to selection of local therapy. Okay, so it is painless and inexpensive. Whereas the disadvantages are it cannot distinguish DCIS and invasive cancer, ER/PR markers, HER2/neu markers, these cannot be determined by this, and false negative results can occur, and we need a cytopathologist who is trained. So these are main disadvantages of FNAC. Then if you see the true cut biopsy, in biopsy it is rapid, relatively painless and inexpensive. No incision is needed. Here ER/PR status can be available. False negative results are less and incomplete lesion can occur, but they are less. Then we have excisional biopsy also. In excisional biopsy, in this the false negative results are very rare. Excisional biopsy, false negative results are rare. Complete cytology before treatment decisions, complete histology can be done before treatment decisions may serve as definitive lumpectomy also. So this excision biopsy is expensive and it is more painful. It creates an incision to be incorporated into definitive surgery. Unnecessary surgery with potential for cosmetic deformity is seen in excisional biopsy. Some cosmetic deformity can occur, so patient may not be okay with that. Next. So if you see the imaging techniques, we will see some important points about imaging techniques. First, mammography. Mammography is the initial investigation which is done in women who is more than 35 years of age, and for screening also we require mammography. This is also the investigation of choice for microcalcification. It is also investigation of choice for microcalcification. Then we have ultrasonography. It is the investigation of choice for any woman who is under 35 years with palpable lesion in the breast. Then we can do ultrasonography. This is not used for screening. Then we have one more lesion, which is MRI, imaging technique MRI. MRI is mainly used for implant related complications. If there is any implant related complications, or if the patient has high risk female, so we do MRI. And also if there in scarred breasts and in implants, in all those we do MRI. MRI is actually the gold standard imaging breast in female with implant. It is actually gold standard for breasts in female with implants. The MRI is the best. Then PET scan. PET scan is used for mainly to diagnose the recurrences in scarred breast. For recurrences, the investigation of choice is PET CT scan. Okay, next we will see some important points about ultrasonography. So ultrasonography in breast disease, it is the investigation which is done in less than 35 years, and those with larger breast tissue and large proportion of glandular tissue is there, which appears soft tissue density, will be seen in ultrasonography. Because of this soft tissue density, mammography sensitivity is less. So as a result, we do ultrasonography. Sensitivity of ultrasonography in detecting DCIS sensitivity is less when compared to mammography. That is why ultrasonography is not a screening method. Why is it not a screening method? Because it cannot diagnose DCIS well. So ultrasonography is an important method for resolving equivocal mammography findings. It is an important method for resolving equivocal mammographic findings. It will also define the cystic masses. And you can find the cystic masses. It can also find almost equal mammographic findings, except that ductal carcinoma in situ sensitivity is less for ultrasonography when compared to mammography. In ultrasonography, breast cysts, if you see the breast cysts, these are seen with smooth margins and echo-free center. Smooth margins and echo-free center will be seen. And if you see benign breast mass, they have smooth, round, oval or regular contour with well-defined margins will be seen. And if you see the breast cancer in ultrasonography, you see presence of irregular margins, but they have smooth margins and they have acoustic enhancement. There will be acoustic enhancement seen in breast carcinoma. So these are important. One more important thing is any patient with high risk, anyone with high risk. High risk means if there is BRCA1 or BRCA2 mutation, or if the patient has any family history of BRCA1, BRCA2 mutation, in them we should do MRI as the screening technique rather than mammography. Okay, now let us learn some important points about mammography also. So in the mammography is the most sensitive in detecting ductal carcinoma in situ. Then screening with mammography is superior to screening of MRI is always better than mammography. Okay, in detecting invasive cancer, especially in younger women, MRI is better than mammography in younger women, because in younger women the sensitivity of mammography is very less because of the dense breasts, because of the dense breast parenchymal tissue. The mammography cannot detect the abnormalities properly. Then, although mammography is more sensitive, it is more sensitive for ductal carcinoma in situ. We do not do it for younger patients. Then, mammography is actually a screening modality, and it can detect the microcalcifications are detected by mammography. This microcalcification is actually the only manifestation. This microcalcification is actually the only manifestation which is seen in ductal carcinoma in situ. So mammography can detect this microcalcification, and the sensitivity of detecting ductal carcinoma in situ is significantly lower in ultrasonography when compared to mammography. So ultrasonography is not used as a screening test, only mammography is used as a screening test. And one more thing, even MRI cannot detect the calcification. So because MRI cannot detect the calcification, you cannot do MRI for even screening the ductal carcinoma in situ. Then if you see some important factors, then if you see some important points about mammography, mammography will deliver radiation of 0.7 C gyre per study, and there is no increased risk of breast cancer associated with the radiation. This delivers almost 25% of this dose is delivered by chest X-ray. So the dose delivered by mammography is 0.1 CGY per study, and this is more than the chest radiography radiation, but still there is no risk associated with breast cancer due to this radiation. It is used to detect unexpected breast cancer in asymptomatic patients. That is, it is used for screening procedure. So you have two views, mediolateral oblique view and craniocaudal view. In mediolateral oblique view, it will image the greatest volume of the breast tissue, including the upper outer quadrant can also be seen with mediolateral oblique view. In mediolateral oblique view, it images the greatest volume of the breast tissue, including the upper outer quadrant and axillary tail of Spence. Whereas in craniocaudal view, this will provide better visualization to the medial aspect of the breast and permits greater breast compression. So greater breast compression is C for C. Greater breast compression is craniocaudal view, whereas mediolateral oblique view will give greater volume. Breast volume is given by mediolateral oblique view, whereas breast compression is given by craniocaudal view. Then next important thing, if you see, mammography is used to guide the interventional procedures. So it is used to guide the interventional procedures like needle localization, and also for needle biopsy we need to do it under mammography guidance. Then sensitivity of mammography is reduced in younger breasts because of their denser breasts, and thus it is not done less than 35 years of age. Then if you see the features of mammography in cancer in mammography. In cancer, you will see solid mass with satellite features will be seen in mammography, and then you will see asymmetrical thickening of the breast tissue will be there, and clustered microcalcifications are also seen in the breast cancer. Okay, fine stippled calcium and also inconspicuous lesions, all those will suggestive of non-palpable breast cancer. Microcalcifications are also an important sign for diagnosis of cancer in young women. Then what about the advantages? Advantages of breast cancer, if you see advantages of mammography, there will be 33% reduction in mortality is seen. Mammography is more accurate when compared to clinical examination for detection of early breast cancers. And also mammography can be started at the age of 40 years, and breast examinations can be done yearly, and yearly mammogram should be taken. So in screening, you should start it at 40 years and every year you should take one mammogram. Mammogram will also help in reducing the stage 2, 3 and 4 cancers in screened populations with a 30% increase in survival. Overall survival occurs from mammography. So this is the important thing. Next, if you see mammography, benign lesions, what do you see? And malignant lesions, what do you see? In benign lesions, you will see smooth margins are seen. Here you will see ill-defined margins will be seen. Irregular, stellate, stippled margins, speculated margins with comet tile will be seen in malignant lesions. In benign lesions will be low density. They will be high density. Malignant. Benign lesions are homogeneous, whereas malignant lesions are heterogeneous. Benign lesions have thin halo around them. Malignant lesions have wide halo around them. Benign lesions, you will see micro calcifications. Malignant lesions, benign, you will see macro calcifications, that is more than 0.5 millimeters, that is macro calcification will be there. Benign, you will see micro calcification of less than 0.55 millimeters. And in benign, breast, nipple, skin, Cooper's ligaments and subcutaneous retromammary space, everything will be normal in benign lesion, whereas in malignant lesion, nipple is retracted, skin is thickened, Cooper's ligament are thickened or increase in number, and subcutaneous retromammary space is also obliterated in malignant lesion. Then we have something called as BI-RADS. So what is BI-RADS? BI-RADS is breast imaging reporting and data system. If it is 0, then it means that it is incomplete assessment is seen and we need additional image evaluation. If it is 1, it is negative. That means routine mammography for 1 year is recommended. Then if it is 2, that means it gives benign lesions. That means routine mammography should be done in 1 year. Then it means it is probably benign. Then you should do short-term follow-up should be done. If it is 4, then that means suspicious, abnormal. Then in suspicious, you should do biopsy. If it is 5, then it is highly suggestive of malignancy. Then you should definitely do an appropriate action. If it is C, it is known or proven malignancy. So these are the 6 stages of BI-RADS. 0, incomplete assessment and needs additional imaging. 1, negative routine mammography is needed in 1 year is recommended. 2, benign findings routine mammograph in 1 year is recommended. 3, probably benign findings short-term follow-up is recommended. 4, suspiciously abnormalities are seen, biopsy can be considered. 5, highly suggestive of malignancy, appropriate action should be taken. 6, known or biopsy proven malignancy. Then what about the calcifications in breast tissue? In carcinoma, you will see micro calcification. In fibroadenoma, you will see popcorn calcification. In fibrocystic disease, you will see powdery calcification. In fat necrosis, you will see curvilinear calcification. So, popcorn calcification in fibroadenoma, powdery calcification in fibrocystic disease, curvilinear calcification in fat necrosis. Then, if you see the risk factors of breast cancer. So, age, it increases with age. Country of birth, most common in Western countries. Family history, genetic factors, especially BRCA mutation is associated with breast carcinoma. Hyperestrogenemia, that is early menarche, late menopause is associated. Nulliparity and obesity is associated. Then late full-term pregnancy is also first full-term pregnancy is also the risk factor. Then alcohol and high fat diet is also a risk factor. Personal history of malignancy is a risk factor, especially in the contralateral breast. And also if there is cancer in the ovarian and endometrial cancer, then it is a risk factor. High socioeconomic status, radiation exposure, hormone replacement therapy. So all these are risk factors. So main risk factors are age increases with age. Country of birth, it is most common in Western countries. Family history and genetic risk factors like BRCA are seen. Hyperestrogenemia like early menarche and late menopause is a risk factor. Nulliparity and obesity is a risk factor. Late full-term pregnancy is also a risk factor. Alcohol, high fat diet, personal history of malignancy like contralateral breast cancer, ovarian and endometrial cancer, previous benign breast disease, high socioeconomic status, radiation exposure, and hormone replacement therapy. All these are the risk factors of benign breast disease. Combined estrogen and progesterone hormone replacement therapy is associated with increased risk of breast cancer, but only HRT, only estrogen HRT is given, only estrogen is given, then it is not a risk factor of breast cancer, but estrogen and progesterone combined oral contraceptives are increased risk of breast cancer. Next, smoking and oral contraceptive pills are not an increased risk of breast cancer, and breastfeeding is protective factor for breast cancer. Then if you see the proliferative lesions, first we have proliferative lesions, relative risks for developing breast cancer. So if you see the risk and the lesions, so first we have proliferative lesions. Proliferative lesions, 70% are seen. So these include adenosis, cysts, duct ectasia, and also mild epithelial hyperplasia of usual type is seen in non-proliferative lesions. Non-proliferative lesions are of 70%, which include adenosis, cysts, apocrine change, ductal ectasia, mild epithelial hyperplasia. Then we have proliferative lesions. Proliferative lesions will be 26%. These include hyperplasia of unusual type, moderate to florid type of hyperplasia will be seen, and also papilloma and also sclerosing adenitis. Hyperplasia, papilloma, sclerosing adenitis are proliferative disease without atypia. Proliferative disease without atypia is hyperplasia, papilloma, and sclerosing adenitis. Then if you see the proliferative disease with atypia, this include atypical ductal hyperplasia, and it also includes atypical lobular hyperplasia is seen. So if you see the proliferative lesions, relative risk for developing invasive breast cancer, first we have non-proliferative lesions like adenosis, cysts and apocrine change, ductal ectasia, mild epithelial hyperplasia of usual type. Then proliferative disease without atypia include hyperplasia of usual type, moderate and florid hyperplasia, papilloma, and sclerosing adenitis. Then if you see proliferative disease with atypia, these include atypical duct hyperplasia and atypical lobular hyperplasia. Okay, next if we see the differences between BRCA1 and BRCA2. So what do you see in BRCA1 and BRCA2? BRCA1 is seen on chromosome 17, BRCA2 is seen on chromosome 13. BRCA1 associated cancers are invasive ductal cancers. It is poorly differentiated, ER/PR negative, and it is early age of onset, bilateral, associated with ovarian, carcinoma, colon, and also prostate cancers. Whereas BRCA2 is also seen in invasive ductal carcinoma. It is actually well differentiated with early age of onset, bilateral, and it is associated with ovarian, colon, and pancreatic, prostate, and also gallbladder, and also stomach carcinomas are also associated with BRCA2. So BRCA1 is on chromosome 14. BRCA1 associated breast cancers are invasive ductal carcinoma. It is poorly differentiated with hormone receptor negative, early age of onset, and bilateral. It is associated with ovarian, colon, and prostate cancers. Then if you see BRCA2 is seen on chromosome 13. BRCA2 associated cancers are invasive ductal carcinoma, which are well differentiated, invasive ductal carcinoma, well differentiated, hormone receptor positive. It is associated with colon, pancreas, prostate, then colon, pancreas, prostate, gallbladder, stomach, and also the melanoma and also colon carcinoma are seen in BRCA2, which is well differentiated, hormone receptor positive. So this is the differences. Then if you see the important thing, that is if you see the incidence of association of breast cancer, hereditary breast cancer and sporadic breast cancer. Sporadic breast cancer is seen in around 65 to 75% of cases, and it is then sporadic breast cancer is around 65 to 75%, and if you see the familial breast cancer, it is around seen in 20 to 30% of cases. So sporadic breast cancer is seen in 65 to 70%. Familial breast cancer is seen in 20 to 30%. Then we have hereditary cancer. This hereditary cancer is seen in 5 to 10% of cases. So maximum it is sporadic breast cancer and followed by familial breast cancer, then hereditary breast cancer. This hereditary breast cancer can occur due to BRCA1, BRCA2, P53, that is Li-Fraumeni syndrome. It is also associated with Peutz-Jeghers syndrome, Cowden syndrome. You will see breast cancer, and you will also see Moore-Twoyer syndrome, ataxia telangiectasia. Ataxia telangiectasia has least incidence. So incidence of sporadic breast cancer is 65 to 75%, familial breast cancer is 20 to 30%, and if you see hereditary breast cancer, it is seen in 5 to 10% of cases, with BRCA1 seen in 45% and BRCA2 seen in 35%, and P53, which includes Li-Fraumeni syndrome, in 1%, and STK11, that is LKB1A, which is Peutz-Jeghers syndrome, Cowden's disease, that is P10 mutation, and Moore-Twoyer syndrome, and ataxia telangiectasia. Among all, least is ataxia telangiectasia. Then for assessment of carcinoma, we have carcinoma breast. Risk factor assessment is present. According to carcinoma breast risk assessment, we have two models. One, we have Gale model, and second, we have Claus model. This Gale model is most frequently used. So if you see Gale model, will have four things. One, age at menarche. Gale model and number of breast biopsies are important, and age of first live birth, and also the number of first degree relatives with breast cancer. So in Gale model, we have age at menarche, number of breast biopsies, age at first childbirth, and number of first degree relatives. So it is age at menarche, number of breast biopsies, age at first live birth, and number of first degree relatives are seen in Gale model. Then we have Claus model. In Claus model, it is based on the assumptions about the prevalence of high penetrance breast cancer susceptible genes. So it is about prevalence of high penetrance breast cancer susceptible genes are seen in Claus model. Then incorporates more information about family history. So in Claus model, it is based on the assumptions about the prevalence of high penetrance breast cancer susceptibility genes. So it incorporates more information about the family history mainly. Okay. Then this estimates the breast cancer risk, that too based on the decade of life, based on the presence of first and second degree relatives, so and their age at diagnosis. So Claus model takes into account the first and second degree relatives and their age at diagnosis. Okay. Next, if you see the ductal carcinoma in situ, some important points about ductal carcinoma in situ. This is among the mammographically detected cancers, half of them is ductal carcinoma in situ. This most commonly presents with calcifications. There are different types of ductal carcinoma in situ. One, we have comedocarcinoma, cribriform carcinoma. We have comedocarcinoma, cribriform carcinoma, micropapillary carcinoma, solid carcinoma, and papillary carcinoma. We have comedocarcinoma, cribriform carcinoma, micropapillary carcinoma, solid carcinoma, and papillary carcinoma. Comedocarcinoma, cribriform carcinoma, micropapillary carcinoma. So we have comedocarcinoma, cribriform carcinoma, micropapillary carcinoma, solid carcinoma, and papillary carcinoma. Then next, if you have, it is also of two types. Next, it is also of two types. One, we have low grade type and also high grade type. Low grade type are mainly cribriform type, papillary type, and micropapillary type are low grade type, whereas high grade type are solid and comedocarcinomas are high grade type. Then if you see lymphatic metastasis of the breast, so from subareolar lymph node of SEPI, they go into the cutaneous lymphatics, and from the cutaneous lymphatics and inflammatory lymphatics. So lymphatic spread of carcinoma breast occurs through the subareolar lymphatic plexus of Sapis, called as Sapis lymphatic plexus. From there they go into the cutaneous lymphatic plexus, and also occurs through subareolar lymphatic plexus and Sapis lymphatic plexus, then cutaneous lymphatic plexus and inflammatory lymphatics. So this lymphatics is almost around 75% will go to the axillary lymph node. Okay, and thus remaining will go into the internal mammary lymph nodes. The tumors in the posterior 1/3 of the breast are most likely to drain into the internal mammary lymph nodes. Tumors in the posterior 1/3 of the breast are more likely to drain in the internal mammary lymph nodes. Okay, then involvement of supraclavicular lymph nodes indicates that it is advanced disease. Then lymph node is treated mainly by surgical dissection and radiotherapy. Then if you see the whole classification, so for this ductal carcinoma in situ, now let us learn about the staging. If you see staging, in the staging, first T1 carcinoma is up to less than 2 centimeters, then that is T1. Then T2 is 2 to 5 centimeters is called as T2. Then T3 is more than 5 centimeters is T3. T4A is if tumor extends into the chest wall. That is if the tumor extends into the ribs with intercostal muscles and serratus anterior, then we call it as T4A. Then what is T4B? T4B is if it involves edema, including if there is powdery orange appearance or ulceration, or if there are satellite nodules which are involved, then it is T4B. So T1 is less than 2 centimeters, T2 is 2 to 5 centimeters, T3 is more than 5 centimeters, T4A is chest wall, extension to chest wall, that is ribs, intercostal muscles and serratus anterior. T4B is edema, which is including the powdery orange appearance, ulceration, satellite nodules are present. But this T4B is not including but in T4B, remember one thing, T4A does not include pectoralis major. Similarly, T4B does not include nipple retraction, it does not include nipple retraction, it does not include dimpling, or it does not include dermis involvement. So, T4B does not include pectoralis, T4A does not include pectoralis major, whereas T4B does not include nipple retraction, dimpling or dermis involvement. Then we have T4C. T4C is equal to T4A plus T4B, together we call it as T4C. Then we have something called as T4D also. In T4D you will see presence of inflammatory breast cancer is seen in T4D. Okay, then if you see lymph node staging N1 mainly involves the axillary lymph nodes. Okay, N1 mainly involves the axillary lymph nodes, but they are actually separate, not matted together, and they are mobile. Metastasis to ipsilateral axillary lymph nodes, and they are mobile. Then this is N1. If it is N2, now if you see what is N2, so N2 we have two N2A and N2B. N2A is metastasis to ipsilateral axillary lymph nodes, but here the axillary lymph nodes are actually fixed and matted. Metastasis to ipsilateral axillary lymph nodes, that is fixed and matted, that is N2A. Then we have N2B. N2B is metastasis to ipsilateral internal mammary lymph nodes. So here there is metastasis to ipsilateral internal mammary lymph nodes is seen, that is N2B. Then we have N3. So we have N3A. N3A, what is N3A? N3A is metastasis to ipsilateral infraclavicular lymph nodes. First, ipsilateral to infraclavicular lymph nodes. Metastasis to ipsilateral infraclavicular lymph nodes is N3A. Then what is N3B? In N3B, there is metastasis to ipsilateral ipsilateral axillary lymph nodes, and there is also metastasis to ipsilateral internal mammary lymph nodes. Okay, there is also metastasis to internal mammary lymph nodes, both of these. That is N3B. Then what is N3C? In N3C there is metastasis to, in N3C you will see there is metastasis to supraclavicular lymph nodes EC, ipsilateral. That is N3C. Then what is M0? M0 is no metastasis. M1 is there is metastasis is present. That is important thing. Then, so in a special condition, if there are two lumps and present in the same breast, if there are two lumps, then which staging will you take? You will take the staging of the bigger lump. Okay. Then if there is lump in each breast, if there are two breasts, if there is lump in each breast, one lump and second lump, then you should stage each lump should be staged separately. Then if there is contralateral axillary lymph node involvement, just remember, if there is any stage, whatever the thing is, if the patient has contralateral axillary lymph node involvement, this is the breast cancer, but if there is contralateral axillary lymph nodes, even in just mobile and separate, even then you should take it as metastasis only. Then, how are you going to manage the breast carcinoma? In the management, first it is early invasive breast carcinoma. Early invasive breast carcinoma, the treatment is breast conservative surgery should be done with axillary lymph node sampling. Breast conservative surgery with axillary lymph node sampling and radiotherapy should be done for early invasive breast carcinoma. For early invasive breast carcinoma, you should do breast conservative surgery with axillary lymph node sampling and radiotherapy. If breast conservative surgery is contraindicated, in such case you should do simple total breast mastectomy should be done with axillary lymph node dissection. Simple mastectomy with axillary lymph node dissection should be done. Now, when do you call it as early invasive breast cancer? Stage 1, stage 2A and stage 2B is called as early invasive breast cancer. Stage 1, stage 2A and stage 2B is called as early invasive breast cancer. Next, if you see the indications, in the indications of chemotherapy are important. Indications of chemotherapy of early invasive breast cancer. So if you see early invasive breast cancer, what are the indications of chemotherapy? If there is high histological grade or if there is lymphovascular invasion, hormone receptor negative and ERPR positive. Sorry, hormone receptor negative, that is ERPR negative, and if there is HER2 neu positive. So these are the indications of chemotherapy in early breast cancer. That is presence of high histological grade, lymphovascular invasion, hormone receptor negative, that is ERPR negative. You will give hormone therapy, and HER2 neu positive, then you should give trastuzumab should be given. So in early breast cancer, chemotherapy indications are high histological grade, lymphovascular involvement, hormone receptor negative, that is ERPR negative, and HER2 neu positive. In these cases, you can give chemotherapy to the patient. Then treatment of advanced breast carcinoma, that is locally advanced breast carcinoma, include stage 3A, 3B, and these include 3C. So in these cases, we will do neoadjuvant chemotherapy is given with modified radical mastectomy with radiotherapy is given. You will do neoadjuvant chemotherapy with modified radical mastectomy with radiotherapy is given. Neoadjuvant chemotherapy, modified radical mastectomy with radiotherapy is given for stage 2 cancer. Then if you see stage 4, that is if there is metastatic disease, then we call it as stage 4. In stage 4 or metastatic disease, with this stage 4, you will have to just try to prolong the survival of the patient, and then you should improve the life of the patient, and hormone therapy is preferred over the chemotherapy in stage 4 disease. So what are the indications? So if you see indications, first we will see indications of hormone therapy and indications of chemotherapy. ERPR positivity is indication of hormone therapy. ERPR negativity is indication for chemotherapy. Then in hormonal therapy, if there are any asymptomatic Visceral metastasis. Asymptomatic visceral metastasis, you should give hormone therapy. If there are symptomatic visceral metastasis, then you can give chemotherapy. Asymptomatic visceral metastasis, hormone therapy is done. Symptomatic visceral metastasis, chemotherapy is done. In hormonal therapy, you will have bone and soft tissue metastasis, whereas in chemotherapy, it is hormone refractory. Chemotherapy is hormone refractory. So, hormone therapy, indications of hormone therapy are ER/PR positive, asymptomatic and visceral metastasis, soft and bone tissue metastasis, that is indications of hormone therapy. In chemotherapy, it is for ER/PR positive and symptomatic visceral metastasis with hormone refractory. Then you do chemotherapy. Hormone refractory cases, you do chemotherapy. Then, indications of radiotherapy in carcinoma breast are. So, if you see the indications of radiotherapy now, right? Yeah, indications of radiotherapy in carcinoma breast. If you see the radiotherapy in carcinoma of breast are, we can do breast conservative surgery. So, if you see what are the indications of radiotherapy in carcinoma of breast, radiotherapy are, it is done in breast conservation surgery, it is done in locally advanced breast cancer. So, radiotherapy is indicated in breast conservation surgery, locally advanced breast cancer, 4 or more lymph nodes, or it is seen in positive margins. It is seen in breast conservative surgery, locally advanced breast cancer, 4 or more lymph nodes, or it can be done in positive margins. So, radiotherapy in carcinoma breast is breast conservative surgery, locally advanced breast cancer, 4 or more positive margins, and 4 or more positive lymph nodes and positive margins. Then if you see mastectomy. So, if you see in mastectomy, first you will do mastectomy. So, if this is the lesion, if this is the breast and this is the lesion, first you will make an elliptical incision, okay, involving the nipple and areola and also breast tissue and breast mass. The positive, then you have removed it. Once you have removed this incision, then you have sent it for histopathological examinations, and if you see that there are positive margins, if positive margins are present after doing a mastectomy, then you should do chemotherapy. So, if you do a chemotherapy, now the chemotherapy regimen, we have 2 types of chemotherapy regimen are available. One we have has CMF regimen, second we call it as CAF regimen. In CMF regimen, we have cyclophosphamide, methotrexate and 5-fluorouracil, whereas in CAF regimen, cyclophosphamide, adriamycin and 5-fluorouracil are involved. So, in chemotherapy regimen, first type CMF, which is cyclophosphamide, methotrexate and 5-fluorouracil. Second type, we have cyclophosphamide, adriamycin and 5-fluorouracil. So, this is the preferred form of chemotherapy in both these. This CAF regimen is preferred when compared to CMF regimen. Then, usually 6 cycles are given. We have 6 cycles are given, and for adriamycin resistant breast cancer, if any breast cancer is resistant to this CAF regimen or adriamycin, then you should give taxanes can be given to the patient. Then chemotherapy agent given in adriamycin and taxane resistant to breast cancer. Even if this taxane is also resistant, then you can give ixabepilone can be given. If the tumor is resistant to taxanes also, then you can give ixabepilone can be given to the patient. So, in chemotherapy, first you give cyclophosphamide, adriamycin, and you give 5-fluorouracil. Then, if the patient is resistant to cyclophosphamide, adriamycin, and 5-fluorouracil, then we give taxanes. If the patient is resistant to taxanes also, then you give ixabepilone is given. Next, we have HER2 new cancer. If the patient is HER2 new positive, then the first line of therapy is trastuzumab. If the patient is HER2 new negative, first line it is trastuzumab. HER2 new positive, first line is trastuzumab. HER2 new positive, Second line is Lepatinib. Lepatinib is the second line for HER2 positive lesions. Then, if you see drug given in metastatic and breast carcinoma, metastatic and refractory breast carcinoma is, we have Sunitinib. Sunitinib is given in metastatic and refractory breast carcinoma. So, what does this mean? Sorry. Then the drug which is given in metastatic and refractory breast cancer is Sunitinib, is given in metastatic and refractory breast cancer. This Sunitinib is actually the first agent for advanced and metastatic breast cancer. This Sunitinib is the first agent for advanced and metastatic renal cell carcinoma. So, if the drug given for advanced and refractory breast cancer is Sunitinib, this Sunitinib can also be given for advanced and metastatic renal cell carcinoma, and this Sunitinib is also drug of choice for imatinib resistant breast carcinoma, imatinib resistant GIST. So, it is also the first line or drug of choice for imatinib resistant gastrointestinal stromal tumor. So, Sunitinib is used for metastatic and refractory breast cancers. So, if you see all the drugs, in all the drugs, among all the drugs which are available, first we have Sunitinib. So, First we will see all the drugs, okay, in chemotherapy. First, chemotherapy, it has two things. One, cyclophosphamide, adriamycin and methotrexate. Sorry. Thank you, and thank you for watching.